It's wonderful to see everyone back here again. I'm excited for another day ahead. We're going to hopefully accomplish a lot today and deepen the bonds, of course, that we've already started making with each other. Quick look at the big circle for the day. Our penultimate day tends to be the biggest one. We're going to get down with some issues this morning in small group discussions, work on prioritizing these issues, and then start this afternoon our work on crafting recommendations. Amongst all of that, we've got a couple of wonderful presentations today. We're going to have in just a few minutes these fine folks right here giving us a presentation and interactive discussion around team-based care and the opportunities it presents for primary care systems. And a little bit later this morning, our panel on trade-offs with continuity and timeliness, and talking a little bit more about community-based care and community health centers as well. And then, of course, this evening we'll have Dr. Kathleen Ross, who's already arrived here, who will be part of our Ask Me Anything panel. That will be following dinner back at the hotel in the Sunrise Room. So the agenda in a bit more detail, there we go. Mostly actually just what I went over. I'm going to do a quick lightning recap of kind of where we are here, and I do mean lightning because I do want to get things over to our work today. But I just wanted to call quickly attention back to our May 27th session where we talked about access to care for equity-deserving communities, and we welcomed Dr. Evan Adams, Lindsay Mackay, and Alan Ruddiman to talk about that. And I wanted to emphasize this because they did bring forward, I think, what we also discussed yesterday about social determinants of health and how essential it is that we have a system of records in our primary care communities that includes information of context. And I think this aligns with some of the things that we talked about yesterday, around having primary care providers be more informed about issues of geography, race, disability, language and culture, and especially Indigenous communities that correct those measurable inequities as far as access to care. And so I wanted to make sure those conversations remain present in our conversations for the rest of this weekend. And so that's some of the key points that they brought up as well, and including, of course, essential that primary care includes mental health and addiction service, and as Dr. Mackay noted, requires a lot of collaboration and flexibility and community health models in order to achieve that. We also, of course, heard from Dr. Tara Kiran, who's here today as well last time, presenting about models and features of care from other jurisdictions. You then worked in small groups to kind of identify and work out what some of these ideal features could be. We're going to re-engage with some of those features a little bit later today as we move towards getting some recommendations drafted. And of course, quickly recapping, sorry, the clicker's not working so well. What we accomplished yesterday, of course, our wonderful virtual panel with Lindsay Hedden, Barinder Narang, Kira Peterson, and Gladys joining us virtually from her vacation hotel in Las Vegas to talk all about virtual care. I think Gladys was very wonderful in giving us an idea of what a success story looks like in a rural Indigenous community when virtual care primary services are working well. And of course, Lindsay, Barinder, and Kira gave us lots to think about in terms of how our infrastructure is working or not working to support virtual care, and what we need to do in terms of accountability, technology adaptation, and of course overcoming barriers to access for vulnerable groups who may not be able to access virtual care. So all of those conversations and more will remain hopefully top of mind today. Some of the points that were brought up in last night's conversation about universal interoperable information systems that require infrastructure, accountability, innovation, and of course I think the point was made most prominently that they require political will and public pressure, hopefully of the kind that will come from you as well. Empowering patients to access their records, of course, was a key theme. Considerate and making equitable the needs and abilities of patients who are using virtual care services and technology who may not have the ability or access or know how to do so. And of course, reconsidering models of primary care delivery that are holding us back. And I think this is where I think at the first session in April, somebody typed in their notes, ask the facts, and I know that question was raised again yesterday as almost an example, a metaphor for all of the things that are holding us back and seem to be a little bit funky with the system. So those are some of the kind of key takeaways from yesterday. We also then, of course, worked in groups to continue defining our values. We've captured all the notes that you started working on yesterday. We're not done, of course. We're going to return to our values conversation probably tomorrow morning, by which point we'll have printed out, sort of where you got to yesterday in your groups, and have an idea. We can reflect that back to you to kind of give us an idea of where you want to go towards finalizing those. And I wanted to quickly re-engage with this this slide here about what your final report will be and what it will do, and including what happens after this weekend. The first sort of sections of this report will begin to draft this weekend, and by the time we get to Sunday's closing session, we actually will have a great draft of who we are and why we volunteered, what we learned, the challenges that we want solved, the values that we've identified and defined in draft, and of course, most prominently and importantly, the recommendations that you come up with. We'll have these in a good enough state, I'm sure, to present to our audience tomorrow afternoon at 2:30, but bearing in mind that after this weekend is over, we'll collect all this together in a draft report and send it out back to all of you and give you a couple of weeks to look at it, to reflect on it, to suggest edits, to comment, to say, oh, we forgot this, what about this? To make sure that what we leave here tomorrow is not the end-all, be-all of the final product, but there will be more opportunities for you to re-engage with what you've created here this weekend. In addition, of course, you'll have an opportunity to draft a minority report as well during that 2-week period following. And then after that, once the report is then done, and it'll eventually be published and put out into the world later this summer, the Our Care team, and I know this is a question that's been raised a little bit, they have a media engagement team that we were looking to get a lot of media coverage. The Ontario report was very successful in gaining the attention of major national newspapers, broadcasters, and media, and so on. And we will be continuing that push to make sure that the media are able to amplify what you are producing here this weekend. And of course, the Our Care initiative is set up to monitor the impact that then these initiatives, these reports have when they put together their blueprint for primary care. So that's a quick sort of look at exactly what happens afterward, and I know if there's any other questions about exactly where the report will go, what audience it will reach, and what impact it will have, which of course is the big question here. We'll be glad to continue to address those questions as the weekend goes on. Wanted to lastly call our attention to, I don't know if you guys are Globe and Mail readers. This was actually in this morning's Globe and Mail. I think Tara has a printed copy over there if you wanted to see it. But it's an article all about how we need to maybe reimagine the organization of primary care, and perhaps radically so. And it does a good job of actually introducing this notion that the way we think about structuring our primary care is quite a lot different than we do with our education systems. And a little bit later this morning when Rita McCracken is here, I know she's going to talk a little bit more about that as well. So we'll make sure we send this all to you if you haven't had a chance to read it. But the other thing I love about this article is it references the Our Care National Survey. It references the Our Care report that was put out in Ontario. And it kind of already shows me and shows us how the work that you're doing is having an impact in terms of even informing our colleagues in the media who are going to be part of putting this out. So it's a really great article, and we'll make sure you get attention to it, but I just wanted to share it with you because it does speak to some of the impact that you will be able to have through your work here. Any other questions or comments before we move on to our first wonderful panel of speakers over here at Waiting with Anticipation?
I have a question about the Globe and Mail.
Yes.
I believe there's a paywall, so when we receive it, will we be able to access it?
We'll find a way to get you around that paywall somehow. Okay?
Thank you.
Yeah, it says right on it 4 subscribers, so.
What's that?
It says right on there's 4 subscribers.
Yeah, exactly, 4 subscribers. So we'll make sure we find a way to overcome that somehow. I pulled that up through my subscription this morning.
I'm sure that
Globe and
Mail has more than 4 subscribers.
They do have more than 4
I'm sure
subscribers?
they have more than 4 subscribers.
Yeah, absolutely. Any other questions? All right. Well, let me turn next to our first wonderful group. And at this point, before we get going, for our presentation today, they're going to be doing a little bit of interactivity at their tables, which is going to be, I think, fun and exciting and very informative. So in order to make 4 tables, can I ask folks back there, looks like our table over here is already helpfully moved. If you folks would mind finding a seat over at one of these tables over here just before we get started, you'll be able to move back and keep working there when we're done. And if we need to bring in a couple of more chairs, our facilitators can help with that. So just give everyone a sec to relocate and we'll get started. All right. Thanks, everyone. I am very pleased to introduce this fine group of people over here. Dr. Pham, raise your hand. Hayley Diakiw. Thank you very much. Sorry, I know I wrote that down somewhere. Estephanie Acebedo and Davana Harlow, who've come to us from Victoria. Their work with the South Island Urgent Primary Care Centers and Gorge Urgent Primary Care Centers in Victoria, in my current hometown. And of course, we also have joining us on Zoom, Valerie, are you there with us? I don't know if you can hear us, Valerie. Valerie St. the Executive Director of the British Columbia Association of Community Health Centers. And this morning's presentation is all about teams and team-based care. And I think, was it Matthew? Somebody kind of made a half joke, which may not have been a half joke, I think, last time about how teams and team-based care might be a subtitle of the report. It's an issue that everyone has already been curious about, they've already engaged with a little bit, and they're really excited to have you kind of give us a little bit more of a practical interest in what teams are doing right now and what they are capable of doing, especially in the future in terms of improving these issues around access to primary care in the province and filling in some of those gaps. So without further ado, can I welcome you to come on up? I'll do the clicker for you.
Good. If you want to start on slide 1, please.
Yep.
All right. So because this is a talk about team-based primary care, obviously we'd come as a team to really give you an impression of what it means operating with 4 brains and 8 hands, because that's really very differently approaching primary care and family medicine. And we have Valerie here on Zoom, as you know, and she'll be doing the land acknowledgement for us in a second as well. Next slide, please. So why are teams important? I like this whenever I think about it. It's really, if you want to go fast, go alone. And I think that was the previous attitude. And I sometimes see this attitude still amongst my colleagues, that's the thought, I can just do that much faster on my own. But I think if you want to go far, you really have to go together. And we have huge mountains to climb ahead of us. And that's why today we'd like to really talk about what each member of the team contributes and why we all benefit from that. Next slide. So we wanted to do it interactive. It is morning. You all have squished together into 4 tables because we have 4 facilitators in about 20 minutes from now, because we wanted to give you all an opportunity to work through things together in a smaller round. It's less intimidating for us, and it allows you to ask questions at a deeper level. And I'll be talking about some of the things that you might already be familiar with in BC and maybe not. What's happening across Canada, just a little bit. I will not talk about international models, but there is lots of team-based primary care in other jurisdictions, obviously. We'll talk about the teams and why we're so much better together as a team. And then really after some of the table work where you've been able to talk to each one of us as people, come back together for a final Q&A. Next slide. All right, why do we need teams? When I think about that, it's really, medicine has changed drastically. You know, about 100 years ago, it was the Lone Country Doc, but today, I'm the 3rd opinion on the Google Doc. And when you think about it, penicillin hasn't even celebrated its 100th birthday yet, but the amount of medications that can interact with each other, the complexities of medicine have changed quite a bit. And patients are much more engaged and should be so. And so there needs to be time spent counseling, talking about preventative care. What can you do to stay healthy? While I'm sure in the olden days you just gave that penicillin if you had it, and that was that, out the door, next one. So those are some of the changes that you all know about. We're not just talking about acute illnesses, but we talk about health promotion, and we talk about really high quality chronic disease management. Next slide. So obviously we're here in BC. As you see, we're looking east in this case. The sun must just be rising. And so there are a whole bunch of things going on out east, but for now we'll want to focus first on what's going on here in our home province. So I thought I will hand the mic first to Valerie, who really will talk about community health centers, because that's been really a very solid team-based primary care model for a very long time in BC, but actually across Canada. And so Valerie, with that, first to you.
Recording in progress.
Thank you so much for the introduction, and thank you for having us as part of this important work. So I'm assuming you can see my slides. I can't see them. And so I'm the Executive Director of the BC Association of Community Health Centers. And we support this care model, and we support communities interested in developing one of these care models. So we have 5 criteria that we use in BC and actually across Canada to define what a community health center is. These 5 criteria are also embedded in Ministry of Health policy. And so the first principle is that a community health center provides team-based, interdisciplinary primary care. So very much having team-based care embedded in the service delivery model. The second principle indicates that community health centers not only have primary care services, but they integrate these services with health promotion services and support and community wellness and well-being. So they integrate in their community across all kinds of support that come together for patient well-being. A community health center is community governed, which means it's a not-for-profit or cooperative organization that provides service and has a board made up of community members. The CHC actively addresses the social determinants of health, in addition from a focus of well-being for the patient, and also demonstrates commitment to health equity and social justice, which means that the focus of the center is also on vulnerable populations in community and supporting access to care by individuals who don't necessarily enjoy or feel comfortable accessing care in the mainstream health system. And so it's a different model, as you can see. Next slide talks about the 50 years of history in BC of community health centers. We have Reach Community Health Center, which is the oldest, and that is in Vancouver, supporting the community there, and they are 50 years old. We have Kool-Aid as an example in Victoria, and we have Mid-Main as another example of our oldest CHC in BC, and they're located in Burnaby. We have 31 CHCs currently operating in BC. We have 10 proposals waiting approval for 10 additional community health centers to open, and we have another 12 communities that are exploring the community health center model for access to care in their region or in their community. So there's a diverse mix of urban and rural settings for community health centers, which means that there's a diverse mix of populations that are served. And the services are very heterogeneous. And so we like to say, when you've seen one CHC and the model of care that they have and the team that they are working with, you've seen one CHC, because each and every one is different. I mentioned that they are community governed, which allows for community needs to be identified and met by the service delivery model, and also for community needs as they change to be met through the CHC through adjustments. There's broad programming offered in addition to primary care services in a community health center. And so health promotion and social determinants of health, such as food security supports or housing supports, are also provided through this model if needed in community And at last count in 2020, we had over 150,000 people around the province accessing care or services through a community health center. And we're updating those numbers as CHCs continue to spring up around the province. Next slide gives you 3 examples of specific community health centers. Kool-Aid in Victoria, Umbrella Multicultural Co-op in New Westminster and Fraser Valley, and Galliano Island, which is a rural example of a community health center. And you can see here that each of these centers has different kinds of care provided through different kinds of teams made up of different clinicians and practitioners. The Kool-Aid in Victoria has primary care, they have housing, they support folks in the street who are struggling with addictions, they offer dental care, outreach, and they have a mobile van that provides mobile service, taking care to the street where folks need it the most. And they work with a general practitioner, a nurse practitioner, they have counselors, a dentist, they have pharmacists, and a social worker, just to name some of their team members. Umbrella is an interesting organization in that it focuses on the migrant, farm worker population, newcomers and immigrants located in the region of New West and the Fraser Valley. And so that, as you can imagine, is a different care model. They work currently with some GPs, nurse practitioners, social workers, physios, outreach workers, which are different. And these outreach workers support patients who need care in 9 different languages. And so very much aligned to provide service to meet the needs of their specific population. And Galliano Island is an example of a rural community health center meeting the needs of their rural population through providing mental health services, primary care, mental health and substance use supports, dental care. They have a food security program. They have a lab for testing and home support. And they do that through their team of a general practitioner, nurse practitioner, registered nurse, social worker, occupational therapist, a speech language pathologist, dietitian, and they put virtual care and telehealth into play to have access to care for their patients. So next slide gives us a sense that basically the philosophy of a community health center is that any door is the right door for a patient to access care, and care is very broad-based. Teams enjoy working in this model with the patient at the center, and patients appreciate the multidisciplinary approach as well. We have a video that we can share with you, and it is the team at the Steps Community Health Center in Kamloops, and they talk about how their team focuses on patient care. They currently operate through 3 sites in Kamloops, and they have 19,000 patients attached to their 3 sites and their nurse practitioners and GPs. So if we can roll the video, that would be great.
Steps is a nonprofit here in the Kamloops area that provides a variety of primary care services.
Steps is about giving great quality care from a team-based perspective, really patient-centered. You know, how can we not look at a patient just from one angle, but every angle?
It's not the family physicians here that are doing the business of running the organization.
Doctors aren't business people. They train medically, but then what we do in primary healthcare is we put them out in the world and tell them to be entrepreneurs and to get a lease and to hire people and get loans. And so Steps, what we do is that we take care of that overhead and the staff and all of the business side of things, so doctors can come in and they can just be a doctor.
You know, I like to work in a team, always. We have a great support from our administration, from our clinic manager, the social worker, and the counselor.
I'm the extra arm of the physician, and many physicians can only take folks so far, and that's why we all work within our skill set.
If something's going on for a patient, we can be creative in who's going to get involved in how we approach it.
My job satisfaction has increased with working in this type of environment, for sure. Knowing that there's just somebody to help rather than working in a silo.
I'm not as good as Tess at doing counseling. I'm not as good at resolving social problems as Kayla, the social worker. And I would be not spending the government's money wisely if I was using my payroll to do those things.
It's a win for the patients, it's a win for the doctors, it's a win for taxpayers.
Steps has been hugely successful in the Thompson region.
I think that community health centers are the future. They should be.
And that concludes my conversation with you this morning. You want me to disappear?
Thanks so much, Valerie. That was awesome. Such a nice video as well, and a great transition back into the room right now. So you've now heard about community health centers, and we're going to move on to some other models of team-based primary care that are already operational at the moment here in British Columbia. I'm just getting the slides all set up. So as you know, we come here from Victoria, and we essentially are one team that operates within an urgent and primary care center. Well, we're really 6 urgent and primary care centers in the South Island, in Victoria, and the pressing problem that we have is that about 100,000 people don't have a family doctor, and they haven't had a family doctor for, sometimes I hear 8 years, 12 years. And so the problems then arise is, I come from a model in Ontario where I had a patient panel of 1,200 patients for 20 years. And now you arrive and you need to think about solutions for all the other people who haven't had a family doctor. And so you need to kind of act on steroids and address the issues. And they might be very different than here in Vancouver, where the urgent and primary care centers have to solve other gaps because many of the patients here might have a family doctor. And you have to here think about how can you create access through the urgent and primary care centers in the evening, on the weekends, on stat holidays. So urgent and primary care centers, similar to CHCs, might have a common vision, but the problems might be very regional, dependent on what your community struggles with. So that's the first thing to understand when we think about these common models. But when you look at what urgent and primary care centers were tasked to do, it's essentially provide same-day access. That's 8 to 8, Monday to Sunday, holidays included. We have now 30 across the different health regions. And similarly, as you heard here from the CHC model, the staffing, the administration, the management is done, in this case, by the regional health authority. So in my land, it is Island Health on the whole island. And so similarly to the CHCs, the clinicians come in and do the clinical work, but they don't have to think about, if COVID, if 3 staff are out, who's going to man the desk, answer the phones? And how do we find 5 more nurses if 3 of them are sick? Those kind of questions. So that's a difference to the previous model before. Now, a third model that exists, and that is the model that other provinces have already pursued much more, but that has been introduced in BC as well. And one example, I gave you the website as well, is Whistler 360 Health Collaborative. And essentially, they've created a not-for-profit board of directors that governs money for the team. And so they come together, similarly, a group of physicians and community members, and decide our community, in this case Whistler, obviously, needs to think about these are the needs. We need that many physicians, that many nurses, this many, maybe social workers, podiatrists, physiotherapists. They come together as a community and think about that and govern that money annually and report back to the Ministry of Health how they have distributed the monies and spent them. So that's a different way of organizing as opposed to the large health authority that governs the whole region. That model actually has been used quite commonly in Ontario, my previous home province. And so I had run a family health team for 15 years, and we had a board of directors that governed the annual budget, from which we then hired nurse practitioners, nurses, social workers, and we'd report back to the Ministry of Health how that we governed it judiciously, obviously. And similarly to the other teams and what you've already heard, there's a common core team. So that's the next question for all of you. What should be some of the common core team members that you would need for each community to address the needs of your town, your region. So some might need more dietitians, some might need more social workers, some might need a care navigator, some might need a physiotherapist. So those are decisions that can be made locally. And I think what the difference often has been with family health teams and these non-for-profit boards is that physicians were members of the board. And I've been the president of my board of directors together with community members. And it has allowed us sometimes to move much faster. So during the COVID pandemic, for example, all the community members would look at us, what do you think we should do? What are the clinical services we need to create within 3 weeks' time, 2 weeks' time, a week time? So that is one of the benefits that you have when you have physicians working hand in hand in decision making, particularly when you need to move something fast within smaller boards and organizations, as opposed to a large regional health authority. If I want to do something fast with an island health, I do have a whole bunch of committees to run through before something can be done. Quebec. Quebec has decided to do take the CLSC model, or the Centre Local de Services Communautaires, and it is fairly similar to the CHC model. And as you heard from the speakers yesterday, BC, just like Ontario, is a province of pilots, but you never scale it up. So as you heard with the CHCs, at least within, there are CHCs, 150,000 people are taken care of, but how many are we in BC? 6 million, right? So why wasn't that expanded faster, more rapidly, maybe a mini Redux, whatever version? It wasn't scaled up. And so Quebec took the way and just said, this is what we're scaling up. Are there problems with it? Most likely too, and I know of them as well. Access is just as big a problem, but at least they decided we'll take one model and just scale it up consistently across the province. So the question for you arises, how do we scale up team-based primary care? Do we allow a multitude of 10,000 different flowers? Or do we say, no, we should have, 2 or 3 consistent models and then go run and run fast. So don't let too many flowers bloom. We're going to talk about that maybe more at the very end in the Q&A section about the practical steps, how to organize and really land at 1 or 2 or 3 different models of team-based primary care from an organizational level. But I wanted to now turn and also have you think about, at a core, who should be on your team and how do you make teams effective, in fact. Because we have been given money for teams. The BC government has given money to primary care networks, or PCNs, that are local networks. So in my region, there's the Victoria PCN, there's the South Island PCN, and it was meant to bring organizations within the region together to then design the teams and make, give the money to nurses, nurse practitioners, family physicians, and then go. So who should be hired? That's the question. You have 4 representatives here, they'll talk about their professions. Who we don't have here is mental health consultants, but they are part of the team, they're part of my team. There is money for pharmacists. So anyone who is on 15 medications might benefit from a discussion around it. Can we reduce some of them? And so the PCNs have hired clinical pharmacists to be part of those teams. And how do you access them? How do you consult with them? What electronic medical record will you use, right? What is the communication tool? And physiotherapists, I think, are really important parts of the teams, but many of the teams across the country haven't really dedicated money to that. And so many of the problems that we have are musculoskeletal, and they don't require surgery, but they require rehabilitation. But many, many teams have unfortunately not been funded for physiotherapists, for example. So I know that Richard, in preparation for this conversation, primed us to also, talk with you a little bit about the question of continuity within a team. And so how do we ensure that from that lone doctor model, where you knew your doctor and he had delivered your babies and he palliated your grandma, how do we ensure that piece of continuity where you can say, well, they really know me as a person, not just as a number. So some of the things are, we huddle every morning, we huddle once a week. So there are discussions, we look over the day schedule, who's coming in today, who will need a little bit more help, who knows Mrs. X the best, can you come in as well? So there are daily huddles, there are weekly huddles. I cannot emphasize the importance of one medical record with good communication platforms to communicate highly enough. Yesterday you had that discussion on virtual care, but I think it actually derailed a bit. It was much more about the digital health strategy. And is there a digital health strategy? Which is slightly different from what virtual care is. Ask the facts. You have to have some discussion around that. How can we communicate as a team if the social worker, has to go into 4 different doctors' offices and they're on 4 different electronic medical records, and maybe the 5th one is on paper still, right? So if you decide to work as a team, I can log into my computer system and see what's happening across 3 of the clinics and what the labs are that have come in. It's easy for me to see that all, and I can send messages through that system to the nurse or to the medical staff what to do with that. So that has to be a consideration. And when patients get introduced to a team from the get-go, you get socialized to that idea. We're changing. And for some that's difficult, right? If you're familiar with the system of, I was delivered by Dr. X, then it is a change. I think that's something deliberately you need to just reflect on. Because I've had patients 20 years ago who said, I'm supposed to see the nurse and the nurse practitioner, but I only want to see you, but you're only here 3 days a week because you're giving a talk on Saturday somewhere else. I can't see you then. So you have to get used to the fact that the continuity lies in a team within your record that is shared by the team. You have to trust that your team knows you as a team, not necessarily just, Dr. X knows me and the whole family. It is a change, and it is not easy for everyone. And then what I hear over and over again from patients and families that are very used to team-based primary care, who've then transitioned to that model, is they actually say timely access to care. The fact that I can come in after hours when my kid is sick and has a fever and see any provider. The fact that on a Sunday when I've been struggling with this forever and I don't know if I can go into work tomorrow, but I can call in and talk to someone and they can log into the computer, see my medical record and provide me care. That's actually more important to me and my family than that I see the same provider and I've seen them since I was born, but actually they don't work Friday. Or they're now on well-deserved holiday, but nobody's covering for them while they're away because they're in their own office and there's just nobody who wanted to cover for them. So those are some of the things and trade-offs between solo doctor to moving to team-based care, but also the things that need to be in place for the team. That there is timely access, that you have after-hours access, that you have weekend access, and the team knows you because the record is shared. So yeah, then that speaks to the larger system. And you touched on that yesterday, that patient portal. Even, if I cover somewhere else, if I can't see it for whatever reason, you have access to it and can share it with me. That CT scan that got lost somewhere, nobody knows where it is. If you had at least access to that, then you could just show it to me on your phone. And I have patients who do that, and that's so fabulous. So creating a patient portal that allows you to share that wherever you go. We have parts of that in place. It needs to be in place everywhere. And there are other things that we can do. We can use PharmaCare, Care Connect. I can log into, at least within Island Health, I can log into Cerner, the Island Health medical record system, to see what's happened and find that CT scan with your clinician. So those are some of the larger system pieces that you touched upon yesterday that I know you all want, and some of that will be patient-driven, and some of that is creating the connectivities for us sitting in the community. Because I sit within the Urgent Primary Care Center, which is a health authority-run clinic. So for me, it's a click of a button, and I can get straight into the hospital records and find that CT scan for you, if it was done within Island Health. But if you're a community family doc, it might take you 5 security logins, and what password did I use, and then I get a secure code clicked over. So those are some of the barriers why someone might not do it, in their community practice, as opposed to running out of a larger center, a larger clinic where the interconnectivity is much better. So here you see that intersection between team-based primary care and digital connectivity and the digital health strategy that you discussed yesterday. So over to the team, back onto the ground.
So I wanted to talk today about what a nurse practitioner is. So I'm Hayley. I'm a nurse practitioner that works at the Gorge Urgent Primary Care Center. Previous to that, I was a registered nurse, and I worked in the emergency room for 6 years. So what is a nurse practitioner? It's an advanced practice nurse, and they have the ability to assess, diagnose, and treat various health issues and diseases. We can prescribe medications, we can order blood tests, we can order medical imaging and interpret those results. We can work independently in primary care. We don't have to be under the supervision of a physician, and we also work in hospital settings. In primary care, we do have a fairly similar role to a GP. So in BC, currently there are around 900 nurse practitioners, and we are a growing workforce. Since 2017, we have doubled. And in 2022, Health Minister Adrian Dix announced an increase in funding for nurse practitioners, and since I graduated in 2020, the seats at University of Victoria have doubled. So the most common question that I get is, okay, well, what's the real difference between a nurse practitioner and a GP? So I think it's helpful to educate you on what the training is, because, like I said, it's one of the most common questions. So for me and all nurse practitioners is we have a 4-year undergraduate degree in nursing. So you work as a registered nurse, and then there's a minimum number of hours that you have to work. And then you go back to school and get your 2-year graduate nursing degree. Family doctors, they have a 4-year undergraduate degree in usually a science, but it can be various degrees. And then they go to medical school, which is another 3 to 4 years, and then they have a 2-year family medicine residency. So our approach is a little bit different at times, whereas we say nurse practitioners can have more of a nursing-centered, holistic approach, and family doctors have more of a science-based training. But that being said, there's a lot of overlap between the two of us. First practitioner, so we recognize the area.
Thank you, everyone. I'm Stephanie. I'm going to be talking about the role of nurses in primary care. So nurses in primary care. So I'm going to start and give you some example and just talk a little bit more about the topic. So the first one is comprehensive care. So nurses have been part of our life cycle from childhood to adult life and to elderly care. So sometimes we don't realize that nurses have always been here. Nurses have been doing wellness baby checks and providing childhood vaccinations, rolled out the COVID-19 vaccines when it happened, and also providing comprehensive geriatric care for our elderly. Collaborative teamwork. We also work in the UPCCs, or the Urgent and Primary Care Centers in Victoria. We work in one roof with all the other allied health providers. I'll give you an example. I had a patient come in for wound care, and it's a specifically nurse visit, and you get to know your patient. So with this particular patient that came in, they opened up to me one day saying they're struggling, they haven't been sleeping the last few months, and they're feeling isolated. So at that time, I explained to them that we do have a social worker in our clinic, and if and when they decide that they can or want to have counseling with the social worker, I can definitely bridge that and reach out to the social worker. As I was assessing their wound, I realized that it was actually infected. So I talked to my provider that was working that day, and I was able to bring them in and assess, and we started them on antibiotics. So this is the wraparound care that we provide at the Urgent and Primary Care Centers in Victoria. Next slide, please. Health promotion and education. The demographics in BC has changed the last 15 years or so, And people have been more proactive in staying fit and healthy. But in saying that, technology has also changed, so people have easier access to Dr. Google, which is sometimes unreliable. So for us nurses, when we provide information to our clients and patients, we do give you evidence-based, reliable, and up-to-date information with regards to chronic disease management, such as diabetes, hypertension, COPD, just to say a few. And patient advocacy and support. So with this one, the example I would give you is I had a patient come in for blood pressure check, and I got some more history with the patient and realized that they are actually at risk for having hypertension. So when I talked to the patient, I said, you need to have your blood pressure checked regularly, but then they said, I can't do it, and I don't have access to a blood pressure machine, and I can't come here every day. So with that situation, we're able to collaborate with organizations in the community, such as the community virtual care, where the nurses can come to your home and do blood pressure checks as needed. And also, there's also community health services that's out there. So the nurses are usually the point person that could work with the organizations in the community and the teams within the urgent and primary care centers. So I'm going to loop back a little bit with my story with regards to social work being part of our urgent and primary care center. So the next speaker is one of the social workers from Downtown Victoria Urgent and Primary Care Center, Davana.
Thank you.
Good morning, everyone. Thank you so much for having us here today. I just wanted to start by saying that I really appreciate the time that you've all put into attending this weekend, because we're patients just like you are. And I haven't had a doctor for 4 years, so if you know anyone, just let me know. Put a plug in there. I have a fellow social work colleague here, it sounds like, yay. And so what I'd like to do today is just, I'll try to be brief, talk about the role of social work in primary care. I just want to be upfront that I am a huge advocate for team-based care. I've only worked in team-based care for 2 years, and it's been incredible. So I'll start with my slides. I'll stop rambling. So I work in the largest urgent and primary care center on Vancouver Island. We receive between 400 to 500 calls every morning for healthcare access. I believe that social work should be a part of every team-based care, and I'm hoping to give you a few more reasons besides just my opinion on that. So in primary care, social workers, we can support the mental and physical well-being of our patients. We can ensure that you have the resources you need to heal, and we can help you navigate the complexities of the healthcare system, which we know that can be very difficult at times, especially if you're moving from other provinces or different health authorities. Social workers, we strive to build a safe and inclusive environment. We recognize and honor diversity and different ways of knowing and different ways of being. And we provide support for life challenges, traumatic events, create change and build resiliency. I'm sorry, I'm better as a social worker than a public speaker. Next slide, please. So to a social worker, your voice is the most important in the room. I want to hear about you and what's important to you and what your values are and what your goals in your healthcare journey are. Social workers focus on fostering therapeutic alliances. We ensure that your voice is heard and that your goals are addressed and that your values are included in all clinical decision making. We advocate for patients and families to be involved in every step of decision making through your healthcare journey, and also that you're provided information that you can understand in a timely manner. Next slide, please. So a lot of words there. So social work, we have our roots in social justice and social determinants of health. We understand the ways in which educational, racial, social, economic, and other social inequities contribute to health inequities. From our lens, we see each one of you as an individual in your environment, within your culture, the importance of family, maybe your social situation, your legal situation, your spiritual context, and how economic influences really impact your overall well-being for all of us. Social work recognizes that significant health inequities exist in our country, and we work to ideally eradicate those for future generations. So an example of that in a team-based care setting, we opened our doors in 2021 in Victoria. One of the first things as social work we did was we collaborated with our community partners. We created pathways with our Indigenous partners. We also connected with mental health, substance use, so that, say, for instance, our rapid addiction clinic has our charge nurse phone, so that if somebody needs to access an appointment that day, they can call the charge nurse and figure out a plan. We've also connected with our shelter sites, and we're very active in assessing the needs of what our community is, and every day we talk about how do we provide more value to this community. Because as Tia mentioned, it's different based on where we live in this province. And while I live in Victoria today, I grew up in a very small town named Houston up in northern BC. So I know what the challenges look like when you live remotely. Next slide, please. So what does social work service actually look like in primary care? It is amazing. So we get self-referrals. Some of our patients can just come into the MOAs and say, I'd like to speak to a social worker. Our nurses, our physicians, mental health consultants also do referrals for social work, because while our mental health consultants do mental health assessments and counseling, we can make referrals for government and community agencies. We can provide emotional support. We're also really integral in the continuity of care. For instance, as I mentioned before, when people come from other health authorities, we support patients to access their health records. We also, because we get to know our patients, and particularly the ones with high complex care needs, we recognize when something's missing. For instance, I had a patient just this week who had come into the clinic. They were concerned she was having a cardiac event, suggested she go to the ER, which she did. She came to see me 4 days later and wasn't sure what the discharge plan was. I'm in Cerner, I'm looking at the ER discharge note, there's no indication of what that plan is for follow-up. So then on her behalf, I could call around and realize, oh, they had actually made an internal referral in the hospital, and because her phone, she doesn't have enough money to pay for her phone minutes, they couldn't reach her. So we were able to facilitate her to have an appointment within 2 days at our local Royal Jubilee Hospital. I feel like I'm missing so many things because I've totally gone off script. I also wanted to say that social work, we also really help optimize physician and nurse practitioner time and their role. I don't know if any of you have experienced what applications look like for persons with disability, Canada Pension Plan disability, disability tax credit, Handy Dart application. I have copies of those if you want to see any of those pages. So what we can do, just picture someone with complex PTSD, all kinds of barriers, not trusting the healthcare system, what that feels like to rather come into a space and really have the time to go through those questions rather than have a 15 or 30 minute appointment where it's like, tell me all your disabilities, because that's all I have for time. So I can provide that additional support where then the physician can spend their time providing medical care, because that's ideally what we all want. Thank you again. And I just wanted to mention, because we haven't we haven't done a traditional acknowledgement yet, so I would just like to acknowledge that I'm in the downtown clinic, they're in the Gorge clinic. Both of our clinics are on the Lekwungen traditional territories of the Esquimalt and Songhees First Nations, and we very much appreciate working and living on their territories. Thank you.
Thank you.
All right, so I was going to skip over this piece because I assume most of you would know what the family doctor does within a team, but then many haven't had a family doctor in 10 years. So maybe I should wrap up with that before we go to the tables. What is different for a family doctor working within a team? It actually isn't the same. It partially is and it isn't. And I just chose that analogy of these, this team here assembling the Queen's cake. And I thought that was a great analogy. Number one, I like eating and I like cooking, but also it does take a team. And as you see here, they all come together and each person has an important part to do. But you actually also have to think about how you assemble that cake. And so money has been given to, for example, primary care networks. We have to, on the one hand, see patients, but at the same time, we have to think about how to create effective teams. How will a nurse most effectively see a whole bunch of patients on their own without even needing to call me in? That is something that, Steph has created. Patients can come in and get their simple bladder infections and their pap tests and their woman care taken care of. I don't even have to step in there, but it takes time to create those pathways. It creates time to think about how do we create effective team-based primary care, who does what within the team, so that in the end, these 100,000 people in my town get access to more care and actually just simply get access. Yeah? And so how do you create that space? How can we accelerate people getting together, creating those structures? That is, I think, the challenge that we all need to deliberately sit together, because funding is there. There are models of care for team-based primary care, but we just have to put it on steroids. So nurses have to have a way to get, up-trained. Nurse practitioners have to find a home where they can practice within a team, so that if they then needed to, call in, many of the nurse practitioners, as you've seen, have been in practice in primary care for how long now? Maybe 3 years, 4 years, 5 years. But they're fairly fresh out of school, and so if they wanted to ask someone, hey, I've never seen this, can you just come in? There needs to be that space, that collaborative team where you can do that. So being under the same roof is one way, but not every community has that benefit. So if you're not under the same roof and you're 3, 4, 5 different practices, you need to make sure, do we talk about all having the same electronic medical record, and within the record a communication platform so that I can quickly ask for a chat or push on a button and have a Zoom, consult, so I can quickly ask, can you have a look at that rash for me quickly with me, although we might not be under the same roof. Yeah, so these are some of the things that where you have to think about both. Is it easier to be one team under one roof? If we don't have that benefit, how can we be one virtual team under 5 different roofs? So by sharing the same medical record, by having regular team meetings, be it on Zoom or in person, and we certainly have had many different opportunities to collaborate virtually. We have about 10 minutes for these, case discussions and individual questions at the tables, because I thought it would give you more opportunity to ask questions in groups of 8 as opposed to you all a group of 30. Is that okay?
Yes.
Good. So each one.